Thank you, sir. Good morning, everyone. This is the case summary of the first case of today's symposium. A 23-year-old man admitted with abdominal pain. Other features in the history suggested acute pancreatitis. He was not on any medications and he was not an alcoholic. His past medical history was significant for an acute pancreatitis before an obstructive uropathy and AKI. During that time, his ultrasound KUT showed left side multiple renal stones and right side hydronephrosis with pelvo-ureteric obstruction due to ureteric stones, and he was undergone right side GT stenting. During his examination, he was afebrile, not pale, not icteric, and he was tachycardic, tachypneic, and hypotensive. Abdominal examination revealed tenderness on palpation with guarding and rigidity. In his basic chemistry, it showed very high amylase levels of 3267, and he was diagnosed. It supported the diagnosis of acute pancreatitis, and further, he showed high levels of corrected calcium. It was 3.12. So the diagnosis was made as hypercalcemia induced acute pancreatitis. Another chemistry showed hypophosphatemia and high alkaline phosphatase level, and his magnesium and creatinine were normal. And intake PTH was done, and it was high, and hypercalcemia, hypophosphatemia, elevated alkaline phosphatase, and elevated intake PTH gave the diagnosis of primary hyperparathyroidism. To differentiate from familial benign hypocalciuric hypercalcemia, uric calcium creatinine clearance ratio was done, and it was high, 0.02. On further investigation, his DEXA scan showed osteoporosis. An ultrasound scan of the neck showed 6 mm sized nodule in the mid-pole of the right lobe of thyroid gland, and it failed to locate any mass in the thyroid gland. Technetium system-AV scan showed failed to locate any parathyroid adenoma. He was suspected to have parathyroid hyperplasia, and 4 gland exploration was done. 3 glands were identified during the surgery except right superior gland. 2.5 glands were excised, and the histology of the excised gland were normal parathyroid tissue. His postoperative biochemistry showed still elevated corrected calcium of 2.84 with intake PTH was 104. So postoperative persistent hypercalcemia and hyperparathyroidism required further evaluation. The repeat imagings ultrasound neck showed 5 mm sized hypoechoic nodule within the right thyroid lobe, and the repeat system AV showed focal abnormal uptake in the region of the right lobe of the thyroid bed. And FNAC of the suspected lesion showed only thyroid follicle cells. And he was further planned to do parathyroid venous sampling. It is a selective venous sampling. It is done at the Department of Interventional Radiology. So what is the role of Department of Chemical Pathology here? A person from the Chemical Pathology Department should be present at the time of the procedure to receive the sample and for appropriate labeling, and make sure appropriate transport to the laboratory and immediate processing and analysis of these highly precious samples. And the labeling of the site is utmost important in this procedure. This is our patient's report. Here, around 20 sites are cannulated and samples are done. Here, all thyroid veins are cannulated and samples are done to locate any pathology in the normally located parathyroid glands, and other sites are cannulated to identify any ectopic glands, if any. And the femoral samples are done to calculate the gradient. Normally, the gradient is dominant value in the specific vein value divided by the femoral vein value is more than 2.5, give a positive predictive value of 75%. and more than 3 give the positive predictive value of 83%. In our patient, the gradient was 25, 5000 in the right middle thyroid vein, and the femoral venous sample was around 190. And it regionalized the region that is drained from the right middle thyroid vein. So it was diagnosed the hyperfunctioning parathyroid gland should be the earlier missed superior parathyroid gland. And he was offered a redo parathyroidectomy. During intraoperative ultrasound of the neck revealed a deep-seated superior parathyroid gland in the right thyroid bed, and right superior parathyroid lesion was excised, and the histology came as chief cell hyperplasia. This was his histology report. And following resurgery, the patient was improved. His calcium came to normal 2.28 millimoles per liter with undetected PTH levels. Thank you. The discussion will be followed.
Good morning, everybody. Primary hyperparathyroidism is a chemical pathological diagnosis. But histopathology is a discipline where we examine the tissue sample under microscope and arrive a tissue diagnosis. Now, in this discussion, I am going to give some insight. How do we get that tissue diagnosis of parathyroid gland after microscopy? First of all, what does a clinician expect from a histopathologist by sending a sample of parathyroid? Sometimes it may be single parathyroid gland, sometimes it may be all 4 glands. Prime question is cause for primary hyperparathyroidism. We have to answer for that question first. Then, what is the extent of the lesion? If it is benign condition, what are the involved glands? Those has to be given in our reports. Then if it is malignant, then we have to say the extension of the disease. Then at last we have to look for any associated or incidental finding of the sample which may helpful to the proper diagnosis, final diagnosis. Then what does the histopathology expect from the clinician? We are not expect much. We want a properly filled request form. That is most important because we are communicating with the lab clinician through this piece of paper. Therefore, it's very important and acceptable sample on time. What do you mean by a properly filled request form? There are characters. One is it should be legible because we are still manually entering our data into laboratory system. We don't have any barcode system, laboratory information system as such, but because most of the laboratories manually do all the entering of the data because we have to transfer these data into our reports as well. Therefore, it should be legible. Better to use block capital letters to write the name of the patient at least. Then, what are the demographic data has to be there? Age, sex of the patient. Those are very important for some instances to take a decision. Then in this case, the parathyroid glands, there are 4. Usually there are 4 parathyroid glands. Therefore, it's very important to label them separately, site and site of those samples. Otherwise, we can't point out the pathology where it is. Then, how many glands involved? If those data are available with them, the clinician, it's better to send those also. Then renewal clinical data. If the patient is having any other condition, any other pathologies, tumors, those has to be any familial condition, those has to be helpful to have a proper diagnosis of the case. Then the clinical questions at last. In this case, it is better to have primary hyperparathyroidism is a clinical suspicion. Then acceptable sample means it should be either in the formalin or fresh, depending on the condition. Now I am going to give some insight, actually speaking, refresh your undergraduate knowledge of parathyroid gland. Usually there are 4 parathyroid glands in our body, but sometimes it could be 2, sometimes it may be 8. That is the range, 2 to 8. The parathyroid gland is a very small gland. It's the size of a raw grain of rice, 2 to 6 millimeter. Therefore, it is hard to find out. It is not like thyroid gland. It does not cause much mass effects at their enlargement because the parathyroid gland is very small. Usually, it is behind the thyroid, but it could be other places as well, ectopic parathyroids. The knowledge of ectopic parathyroid has to be there to identify the culprit of this hyperparathyroidism. Most common ectopic site is paraesophageal. Sometimes it could be in the thymus, it could be in the lymph node of the neck, sometimes even on the pericardium. Then this is a histological appearance of parathyroid gland. It have the parathyroid gland have a delicate capsule and several cellular components. The clear cells that you can see, those are the adipocytes, and I think you can identify the blood vessels as well. Then other cells are the endocrine cells. The main functional unit of the parathyroid gland is chief cell. It is very small. I have marked there, small cell with round nucleus. Then other second most common is oncocytes. It has a very abundant cytoplasm, granular cytoplasm with round nucleus. We label the parathyroid pathologies according to those cellular appearance of the lesion. Now here is another micrograph of parathyroid gland. Here you can see lot of oncocytes with granular cytoplasm, abundant granular cytoplasm. Then lower side you can see here lot of clear cells. Cytoplasm does not have any granularity, very water clear cytoplasm. Then here there are transitional and the chief cells are there. These are the fat. That is the normal appearance of the parathyroid gland. Right. Now the case is biochemical diagnosis was primary hyperparathyroidism. We work based on this diagnosis. Then what are the possible causes for primary hyperparathyroidism? One is primary parathyroid hyperplasia. Then it could be parathyroid adenoma. Hyperplasia means enlargement of the parathyroid gland due to the increased number of functioning endocrine cells. The parathyroid hyperplasia is usually a polymorphic proliferation. In parathyroid adenoma, it is polyclonal proliferation. But parathyroid adenoma is monoclonal proliferation, but confined to the parathyroid gland. Then rarely you can get primary hyperparathyroidism due to parathyroid carcinoma either. Right. Now I am going to display some illustrations. Here you can see in gray color that is the thyroid gland and 4 parathyroid glands. In this case, all 4 parathyroid glands are hyperplastic. This is very rarely occur. 5% of the cases you can get all four glands get into the hyperplasia, it's equal. But most commonly, asymmetrical four-gland hyperplasia can be seen. In this situation, if you take one gland, sometimes you may miss the parathyroid hyperplasia. Therefore, it's very important to assess all glands properly. Better to have all flow glands to histopathological assessment. Now, this is a hyperplastic parathyroid gland. Now, here you can see the microscopic appearance of that. You can see a lot of chief cells, small cells with little cytoplasm, and some oncocytes as well as adipocytes. We label this as a hyperplasia, chief cell hyperplasia, because majority of cells are chief cells. Here, other differential diagnosis for primary hyperparathyroidism is parathyroid adenoma. Usually, most of the time, it is single monoclonal proliferation of endocrine cells in parathyroid gland. But rarely you can get two adenomas in single patient. Now, this is the micrograph of that parathyroid adenoma. You can see a thin capsule at the edge of the parathyroid here. Then thin rim of normal parathyroid tissue. This is an area, well delineated area with large cells. Other picture shows high power of that. Here you can see chief cells arranged along the blood vessels, that is characteristic to diagnose parathyroid adenoma. Right. Then very rarely, parathyroid cancer can also cause primary hyperparathyroidism, in that the behavior of the parathyroid tissue is quite different. It is infiltrating to the local tissue and sometimes into the muscle here, muscle infiltration in blood vessels and perineural even. The morphology of cytology of the high power, under the high power, the mitosis is quite common. Prominent nucleoli, necrosis can be seen. Those are the features that we are looking for malignancy, but sometimes the changes are very subtle. To differentiate parathyroid adenoma and carcinoma is very difficult. Yeah, now I am going to summarize this case. Now, primary chemical pathological diagnosis was primary hyperparathyroidism. Then we received 2.5 gland, which was normal. Then culprit gland label is it as chief cell hyperplasia. Then post-op biochemical normalcy achieved. That means this is a symmetrical hyperplasia of the parathyroid gland. This is a picture of that gland. Chief cells can be seen, lot of chief cells, but if we go for minor details, we can see oncocytes and transitional cells in this gland. Then same time we received the lobe of thyroid, because these parathyroid pathologies are adenomas and hyperplasia commonly associated with other neuroendocrine, multiple neuroendocrine neoplasias. Therefore, it is better to examine the thyroid glands for C-cell hyperplasia and the medullary incidental medullary carcinomas. Okay, thank you very much.
Thank you, Nayana. Now we have already discussed most of the information about parathyroid gland. I'll be discussing important investigation in this case regarding the chemical pathology aspect. Firstly, calcium. So it's the common test that we usually requested in the ward patients frequently. So we have to know something in the pre-analytical phase, what we should know. As you all know, the basics, calcium is the most common mineral in the body around. It's mainly in the skeleton. So the calcium homeostasis is move around the calcium move from the skeleton and to the extracellular fluid blood. So it will be controlled by the parathyroid hormone. And kidney also plays an important role there because the reabsorption in the tubules will also depend on the calcium amount in the body. So the plasma calcium, it's present in three forms. It bound to the albumin and it can be complex with citrate and phosphate, and it can be present as ionized calcium. So when you request the calcium, it should be specified whether you are requesting total calcium or the ionized calcium, because the measuring methods, what we measured, will be different. So the ionized calcium is the physiologically active form, and the special importance in the sample collection because it's the ion. So it can be changed with the pH in the blood. So therefore, you should follow the precautions same as for the blood gas analysis. Ideally, we recommend sample collection for the acid wash tubes or the plain tubes, new plain tubes. Earlier days we used the reusable tubes that was washed in the laboratory because there was no supply for the new tubes. So we had lot of problems with the calcium because there is a possible contamination if you not use proper tube for the collection. And because we want to ensure there is no change in the pH, ideally you should fill the tube with blood and you have to transport immediately, or if there is any delay, it should be transported in ice to ensure that you get the accurate value for the ionized calcium same as in the patient blood. Otherwise, there can be changes of the value. It can be changed from the what is in the patient. So the interpretation, if the patient is actually having acidosis or alkalosis, it can change the value of the ionized calcium. So you should interpret the ionized calcium value with the pH because the H plus ions bind to the albumin and calcium also bind to albumin. So change in the H plus level will cause changes in the ionized calcium. So in the alkalosis, it will cause reduced ionized calcium levels. In the acidosis, there is an increase. So you should first treat the acidosis or alkalosis, then see whether there is changes in the ionized calcium rather than going to treat the ionized calcium value. And for the total calcium, the sample collection, again we request serum sample. We recommend collection for the acid wash tube or new plain tube. And there, if you apply a tourniquet for long time, difficult with blood collection. If you apply tourniquet for long time, there can be a venous stasis and it can cause problems with the total calcium because it causes binding of more calcium for the albumin. So therefore, we recommend apply the tourniquet. Then you identify the vein, insert the needle, then if possible release the tourniquet, then collect the blood. If you can collect the blood without any delay, there won't be a problem applying tourniquet for a short period. Then we can measure the calcium in the urine. We can collect 24-hour urine for the calcium estimation. For that, we provide a container from the laboratory. Therefore, you should send a request to get the container, and in that container, we provide the container with the preservative because we collect urine for over 24-hour period. So we have to ensure that urine is properly preserved there. So we add HCl. Remember, it's acid. So we have to advise the patient that there is a preservative, it is acid. So be cautious about that. Sometimes patients think that there is something inside the container and he will throw it away and wash it and collect the urine. So we have to properly advise the patient regarding the collection, regarding the container. There is a preservative in it. So that is important role. that should be played by the, because we sometimes patient come to the laboratory, sometimes may not. So the doctors in the ward who are responsible for the insurance of proper collection, proper instruction. Then we can get the spot urine samples. That is, we recommend early morning sample, because throughout the day, depending on the diet, depending on the volume of drink that you get, you can change the concentration of urine. So we recommend early morning sample and collecting to sterile container like that, urine culture containers, to ensure there is no contamination. Then there is another term, albumin corrected calcium. What is it? Because as I told you, calcium is bound to albumin. Uh, Changes in the albumin concentration might cause misinterpretation of calcium level. So we use a formula to adjust the calcium value for the albumin. So this is the formula. So if it is albumin low, we adjust it to the 40, and even albumin high, we should correct it. But usually that we talk about the hypoalbuminemia, not the high albumin, but both situation ideally we should correct and get the corrected calcium value. Then there is another test that you request, that is the calcium to creatinine ratio. It can be done in the spot urine sample, not 24-hour collection. We can do calcium to creatinine ratio in spot urine sample, early morning sample, because it's reliably same as the 24-hour collection. The 24-hour collection is a cumbersome test. Instead of that, you can get the early morning sample. Then by that, we can assess the renal loss of calcium. Then what is fractional excretion? Or else it is the calcium clearance ratio. So they are again using the spot urine sample, we can calculate the fractional excretion. What we want is the urine calcium and urine creatinine and serum calcium and serum creatinine. And by using this calculation, we can see whether there is possibility of hyperparathyroidism or the possibility of familial benign hypocalciuric hypercalcemia. So to differentiate, these calculations are important. Then parathyroid hormone, another test that was important in that case, that is the basic physiology. Parathyroid hormone regulates the calcium reabsorption, and it will increase the decrease the phosphorus reabsorption. So you can get an idea about the hypercalcemia patient. You have to do PTH, phosphorus, calcium, those investigation together as a panel for the interpretation. And it will cause problems in the renal failure patients. And again, the vitamin D level assessment also important in these patients. Then the hyperparathyroidisms, we have to do blood investigation and urine investigation together to assessment. And there can be long-term consequences. Patient might be present with acute problems or the long-term complications to the hospital. So that we have to do the calcium and do the assessment to identify the underlying cause for these consequences, like kidney stones, osteoporosis, other neuromuscular problems. The underlying cause may be the calcium. So we have to be investigate to identify the cause. Then the hypoparathyroidism, we commonly see this in the laboratory in the patients who have undergone thyroid surgery. As explained earlier, the anatomical position, the surgical complication will be the hypoparathyroidism. Patient might be present with complications of hypocalcemia, and it can be due to other autoimmune causes as well. And the parathyroid hormone, what you should know about that is, it's a like polypeptide hormone, and it has a very short half-life. And in the detection, in the laboratory assay method, usually in our assay, we have antibodies to detect whole molecule of PTH, but it varies from analytical platform, from one analyzer to another analyzer. But they are using antibody epitope, it will change. So the measuring concentration might be vary from platform to platform. So from the pre-analytical phase, we have to ensure that we can't get the sample and keep it in the ward, then send it to with the delay, because it will destroy the PTH hormone. Therefore, we have to ensure proper transport, and usually what we practice is we are giving appointments for the PTH measurements and do the analysis on the same day immediately after collection to ensure that there is no destruction of the hormones. So this is the instruction forms given by the laboratory for the insurance of proper sample collection and transport. So finally, from this case, from the investigations that we have discussed, the important message is proper sample collection and transport is very important, and the important thing is communicate with the laboratory to get those information, because if you may not be aware about all the information. So there are doctors in the laboratory, so communicate with them, not just give a call to the laboratory and ask from somebody in the laboratory, but talk to the relevant person and get the relevant information. Thank you.
I think that case highlighted the role played by the laboratory in the diagnosis and management of a patient with hypercalcemia, and we can answer any question.
One question. This patient presented pictures of acute pancreatitis. Was confirmed as acute pancreatitis as well. So was it due to the hypercalcemia?
Yes, hypercalcemia.
The question is, when a patient presenting acute pancreatitis, is it, I mean, do we need to do calcium levels?
Yeah. Usually we have to find, when the patient presents with pancreatitis, if the amylase is high, then we confirm the diagnosis, but we have to find what is the underlying pathology. So in patients with pancreatitis, doing calcium is important to assess whether there is underlying pathology that caused the pancreatitis, and this patient has a previous episode as well, and patient had that renal stones, so it give a clue that there is a possibility of hypercalcemia.
Can I ask a simple question? There are two types of calcium: the ionized calcium and the total calcium. Is it easier just to have one of them first? What are the benefits having two separate calcium?
Yeah, the total calcium or the corrected calcium we can use, but the ionized calcium, it will give the at the moment physiologically active forms, especially if you are not assessed with the albumin, and you might not get the exact corrected calcium value, but the measurement method for the ionized calcium is same as the blood gas. We have an electrode and we can do it immediately without any delay, and you can get a idea. But the transport, and if you are sending it for a long distance, so there is a delay, much better to do the total calcium or the corrected calcium. Yeah, cost is there is a different because the total calcium we do the chemical analysis, and the ionized calcium is just like electrolyte. Same analyzer with the electrolyte, we have a option for the ionized calcium. So that the ionized calcium cost will be much less, but it depends on the long term. How much samples you are analyzing, the cost will depend on that.
Thank you very much. Thank you, Dulani, Nayana, and Fasilaas for that interesting case.